is your flow, essentially. We know this for P3, that our heart functions to pump blood. And receives blood to the rest of the body, and it pumps it out the lungs, pulse of the rest of the body. That blood goes around doing what it is supposed to do, and it will tell the heart to be pumped around, and a red cell will suffer such kinetic and potential energy placed on it for as long as survives. For some red cells, that's 120 days, or some shorter time. Until the day they retire, they get through the same vascular system, which is part of the cryptic system. The tongues not necessarily covered. The heart chunks of blood, total volume of blood that's pumped out after 1 minute, but colloquially coupled. Each amount of blood pump by heartbeat will create a stroke for you. Together, when you combine these with that peripheral resistance, you get what you call the blood pressure. And something that we measure regularly. Okay? So when next time you find your flu, just say, I have pressure. You say, yes, A2, you have pressure. Okay? But what they are going to say is, I have high attention is under the state, where predominantly the blood pressure are above normal physiological ranges. Occasionally, they are in normal ranges, so even lower than normal. Like for you, you have pressure. Predominantly within the normal range. Are really excited when you're hungry, and so body shoot up. Sometimes it goes down. Also physiological adaptations of your heart.
The primary purpose of all this circulatory work is to deliver oxygen to the tissues. And so, Dr. Cornelius requested me to keep it as simple as possible, but this stuff is just so hard. We have to think about the oxygen delivery equations. The primary purpose of having a heartbeat is to ensure that you deliver oxygen and push it around the body, bring it back, recycle it, serving one purpose, that is connecting the circulatory system to the atmosphere through the lung. Essentially, your lungs take oxygen in, blood comes from the right side of the heart to pick that oxygen, goes back to the heart, and then is pushed around. The amount of blood that is dissolved in your amount of oxygen dissolved in your blood is called the content of arterial oxygen. Okay? And then essentially that's now delivered by the cardiac output through the rest of the body. Your tissues will extract what they need for their function. We call that the extraction ratio. And the reserve, the balance, is sent back to the heart. Okay? And your body is very forgiving. Across different physiological states, the extraction ratio remains approximately constant, about 20 to 30%. So that means if you see the saturation of blood returning to the heart being significantly less than 70, then you should be concerned. It means that it's not necessarily the extraction that's a problem. It is the delivered oxygen that's a problem. So if you provided adequate oxygen up here, your lungs did their job, then we can now blame the cardiac output, isn't it? So this is a very important thing that we shall be going back to as we carry on. So when there's inadequate delivery of oxygen tissues, we call that shock. And I don't mean this kind of shock, right? Okay? What we're talking about is tissue hypoperfusion, which is a state of inadequate delivery of oxygen to tissues, okay, and causing organ injury if it's allowed to stay on for too long. Many times it comes along with hypotension, but like we learned earlier this morning, you can be in a shock with normal blood pressure, and you can be in shock with high blood pressure. And similarly, you can be in shock with low blood pressures. And the reverse is true as well. So this is really what we talk about. And again, just connecting back to the oxygen issue, the primary purpose of saturation is to deliver oxygen to tissues. So once you compromise oxygen delivery to tissues, your tissues are going to try to sustain and understand that, sometimes the economy is bad. So they try to deploy some austerity measures to survive. But as it continues, you might end up with damage to tissues. which may still recover, but some of them might end up dying and end up in a state called irreversible shock, such that even when you finally deliver Trump's money back to Uganda, our systems will have been crushed for good. It's bad. We need to lead a campaign against that. So essentially, how do we lead this campaign? We need to identify shock quite early, and there are very many things that influence how shock will present. And these are really so many clinical variables. So the age of the patient may determine how they will display the clinical signs that help us recognize shock. Time of resuscitation, comorbidities, any other treatment you've given before, all the things can alter the course of the disease. But generally, we say tissue hypoperfusion. It means the skin will display clinical signs. Your kidneys will display clinical signs in terms of reduced urine output. Your brain has no reserve for oxygen. It survives beat to beat. That is why when you skip a beat, you know. When you skip a beat, your kidney doesn't know. Okay? Your intestine doesn't care that you skipped 3 beats, but you skip a beat. Your brain knows. Get a weak beat, your brain knows, because it depends on a constant delivery of oxygen at all times, and any compromise is going to be registered as a problem. Other systems in your body will also show the same. On the skin, a simple test is really this called capillary fill time. We shall be talking about it in a bit. But see, it is easy to diagnose shock. Remember, I've not mentioned BP in this case, much as it's usually a part and parcel of different types of shock. Okay? Capillary fill time, urine output, mental state, and other compensatory signs in response to shock are things that we're looking at to tell us that we're in trouble. And so shock can manifest through different mechanisms. As Dr. Cornelius and Dr. Nodrin have already helped us understand, you can have challenges with regulation of the tone of the vessels, and that can lead us to what's called distributive shock, where blood is flowing to the wrong destination in larger quantities versus the quantity supposed to distribute there, and then it compromises other central organs. You can have challenges with increased resistance to outflow from the chambers of the heart. You know, so let's say there's increased intrathoracic pressure from a pneumothorax, tertiary pneumothorax. Maybe the chambers can't fill because there's some restriction to expansion of the chambers, maybe because of a tamponade, or there's something obstructing the outflow from the right, you know. And technically, we shall hear from a cardiologist, technically, the cardiologists tend to reserve the left side of the heart to themselves, and therefore the aortic valve and its output system is classified as cardiogenic shock, but in reality the physiology also is obstructive. For example, you have aortic stenosis, or you have got a coarctation, you know, which is quite critical, right? And when you go to volume, you need a volume to fill the vessels, stretch the heart, generate the preload, and activate that nice elastic recoil of the heart to push out a good volume of the heart, of blood, and compromise of that volume will lead us to hypovolemia and cardiogenic. So this diagram has a number of rings around it to show that these types of shock actually cross-cut. There are some characteristics that cut across. For example, looking at distributive shock, whereas the primary issue is tone regulation, these people who have disorders affecting their vasculature also have challenges maintaining the integrity of the intravascular space. And that means there's translocation of fluid to extracellular space, which causes a relative volume deficit. You know, so think about a septic patient who will be getting interstitial edema because they are losing some intravascular volume, you know, and you can go on and on and on. So ultimately, the spiral of shock is that you end up with cellular death, which we are trying to avoid by learning about this today. And time is tissue. Once an event incites shock, your body will try to compensate. It's not saying I can do it alone. It's saying I need help. When Trump takes away money, we need China. We are beggars. Unfortunately, we need China. And if China doesn't come in on time, end up going into fulminant shock that's manifesting, and ultimately multi-organ failure, and ultimately death. Of course, the other way we could compensate is by figuring out how to depend on ourselves. But when I become president one day, we will talk about that. But ultimately, what I'm just trying to bring out here is that through the different interventions your body tries to pull off, you go through different stages of shock. Now, remember, many times, most of our patients present at this stage when they're in profound shock because people don't want to pay you as a health worker. They want to come to you when they are dying. Okay? They think that you do so little. So they know what you do earlier on, right? All they have is dizziness. Why go to you? You know, when they can just drink water, right? But the cause of the dizziness could be something that may be worsened by taking a glass of water, you know, depending on the type of shock. So ultimately, most of our patients manifest at this stage. But also sometimes the patients who come in early, even before pre-shock, and then somehow the work of the devil prevents you from sensing that they're in trouble, okay? And then you only realize the patient is in truly profound shock. So our job today is to understand how to diagnose shock quite quickly. There are multiple clinical signs that are quite readily available to you as a clinician without even using a piece of medical technology, just your 5 senses, right? We have things that have, when the patient goes into shock, there will be manifestations on the skin. The skin is the largest organ that you have, so it will show so many pathologies. For cardiovascular system, we also have the JVP, which talks about the feeling of the heart, and then the heart rate, which is one of the physiological adaptations. It's not very specific, it's very sensitive, but not very specific. So we may not rely on it so much. So when a patient comes to you in shock, you definitely want to examine the extremities. That's the first step. In other words, you have diagnosed shock, you've checked the capillary fill time and it's prolonged, that's more than 3 seconds. They're having altered mentation. They have reduced urine output. 2 or more clinical signs suggest that it could surely be shock because it sings like a duck, quacks like it, walks like it, right? There are other manifestations. So there are other diseases that manifest the same way, but if you have 2 or more clinical signs tying up together in such a patient, then for sure you should suspect they're in shock. So you look for the likely cause. So if the extremities are warm in this patient, then you're dealing with distributive shock until proven otherwise. And our distributive shock, Dr. Cornelius told us this morning that the predominant category is septic shock, right? So a patient comes to you in distributive shock, they are septic until proven otherwise. Your next job is to identify the focus of sepsis, start them on resuscitation for shock, and start them on antibiotics based on the restratification. We're not talking about that today, okay? How often do you see anaphylactic shock, neurogenic shock? That's so rare. I'm quite good at this work, and I see so many patients. But I can tell you it's been a while since I saw neurogenic shock, since I saw anaphylactic shock. So you're likely to see septic shock when a patient is distributive shock, right? If the extremities are cold, then the next part is look at the neck veins, right? If the neck veins are flat, the jugular vein is flat, honestly, I don't care what they are swearing it is. This is hypovolemic shock until proven otherwise, okay? So your job is to start looking for why they are losing volume. Is that they are vomiting, having diarrhea, they want diuretics, or are they bleeding? And usually that's a nasty one. They could be having occult bleeding. They're bleeding internally, okay? Most times they will tell you, if you ask them, have you been vomiting out blood? Like, yes, I vomited a full basin of blood. That is a lie, right? But usually they tell you that kind of stuff, right? If the JVP is, if the extremities are cold, okay, and the JVP is plump, then that tells you it could be cardiogenic obstructive, right? So you want to listen to the lungs, lung bases. If they're having crackles in the lung bases, then it is cardiogenic. If they are having no crackles in the chest, the next question is, how's the air entry on both lungs? If it's unequal, then you're dealing with the tension pneumothorax, okay? if the air entry is equal, okay, then you want to listen to the heart, finally. If you can hear heart sounds very well, dealing with the PE. If you can't hear heart sounds very nicely, in other words, they're so distant and muffled, then that is tamponade. So just a simple algorithm, in under 2 minutes, you have a diagnosis of shock, you have a likely overarching mechanism of shock, and you're ready to start saving life. Treatment is designed to save life in a time-sensitive manner. You work like clockwork, not alone, with friends, usually the nursing staff and other staff within the emergency room, theater, ICU, to pull off this, because everybody goes into shock before they try to die. Unfortunately, I don't know if this image appears nicely on the screens, but what I was trying to bring out here is that many times we provide resuscitation and we correct haemodynamics, right? Correct the blood pressure. Heart rate, I don't know what it was before, but maybe it's dropping already, you know. Things look good, but when you look at actual tissue perfusion, it is still poor. The lactate is high, you know, despite having adequate cardiac output. Okay, patients requiring a lot of norepi. If you check their capillary refill, you'd find that this is slowed. This patient in the original image has a lot of skin mottling, despite having fairly acceptable blood pressure at this stage. Doesn't mean that you switch off. It just means that shock is not exactly about the macrosaturation alone. As your blood flows through the body, it goes through different calibers of blood vessels, and the terminal caliber of tissue of vessels whose size is less than 100 micrometers is termed the microsaturation. That is the terminal arterioles or the meta-arterioles, then capillaries, then venules, before it comes back to the venous side of your blood flow. So it's possible to fix the macrosaturation with a good blood pressure and the like, but the patient is not coming out of shock because the microsaturation is not healthy. So what is microsatulatory failure? So this is where you have fixed the macrosaturation, you've corrected hypotension, but the patient remains in a hypoperfused state, and this happens due to multiple mechanisms. Within the microsaturation, there are different calibers of blood vessels, and this blood is supposed to permeate all of them in adequate quantities to deliver nutrients to keep cells functioning. Now, through this heterogeneity, which is regulated by these small structures called the pre-capillary sphincters, different conditions alter the caliber, the tone of this, and distribute blood haphazardly across the microsaturation. In fact, in some situations, you have blood completely bypassing the microsaturation and going through the metacapillaries all the way to the vein, shunting the microsaturation. So yes, you have a nice big blood pressure, looks cool, people are praising you, now saying, "Doctor, well done." But in truth, your patient is merely shunting through, right? And the lactate is continuing to go up. Mixed venous oxygen saturation, it looks very, very good because you're delivering oxygen, it's not being consumed, it's just coming back up, right? So that is microsatulatory failure. So what are the mechanisms? There are very many mechanisms, I don't want to dwell in it. But besides just the microsatulation, as we mentioned earlier on, that if you delay to fix shock, the patient goes into a state called irreversible shock. On top of disturbing the microsaturation so badly, prolonged shock can result into mitochondria giving up. These are the powerhouses. They say, "You know what, I've been here waiting, I'm done, I'm tired," right? So you come in, deliver oxygen, and looks at oxygen as a poison, and for real it's now a poison. It ends up now causing oxygen radicals to just increase and injure the tissues instead. So microsatulatory dysfunction, together with the mitochondrial dysfunction, constitutes what's called a microvascular mitochondrial distress syndrome, which most times puts the patient in a spiral towards irreversible shock. These are things you want to protect, to prevent. You don't want to diagnose it, okay, in the patient. You want to prevent it. So all treatment of shock must combine all these aspects of fixing the microsatulation as well as the macrosatulation while monitoring organ function. Okay, so how do we monitor it? There's no ideal target for monitoring, the microcirculation and macrocirculation. It's just a combination of clinical signs which should inform you of how the tissues are working, because the specific characteristics are as hard as finding the perfect spouse. It's hard. You have to learn to compromise. So there are so many clinical signs, some of which have been talked about already. I'm just going to pull out some that I think you can do bedside quickly. When you are dealing with a patient with shock, the skin is the largest organ. So you can look at things like the characteristics of the skin. How is the skin feeling perfused? Is it warm? Is it dry? Is it mottled? Okay. Skin tagger can be something that you can use to tell you about the underlying cause. It's a bit difficult in the adults, better in children. Yeah. And many times, even in children, they told us in medical school to pinch the abdomen, right? Yeah. Now, after growing through all the turmoil of life, your skin starts to sag in the belly. At some point, you weighed fairly well, and then somehow life changed. And you shed that weight, and now the skin cannot be relied upon in the abdomen. So recommendation is to use a subclavian skin. Then, of course, the global assessment for shock, things like the urine output and mental state can help you get a clue. So if a patient was in shock and then you start resuscitating and the mental state is getting better, urine output is improving, then you feel like you're kind of hitting it, right? There are the macrocirculatory monitors or tools that we've been taking through, things like blood pressure, heart rate, and the like. But essentially, blood pressure itself is not very reliable. As I said, it's not even included as in the definition of shock. But it can give you a clue that if I was able to achieve tissue perfusion at this map, then maybe if I maintain that map, my patient might have a good chance of coming out of shock entirely and hitting the ground running, ready to repossess their life. Okay, so that's really the purpose of following the BP and heart rate and the like. But I want to just talk about some quick things. Shock index. It is, sorry to say, fake news from our colleagues in the emergency medicine section. And it's very useful fake news. Why do I say it's fake news? An index is a unitless measurement. Okay? Shock index is a ratio of heart rate to blood pressure. Does it have a unit? So will it be an index? So essentially, our colleagues in the emergency department really struggle with the sickest patients with limited information. And I developed this very useful index to try to give a clue to the adequacy of resuscitation and severity of illness, especially in hypovolemic shock. So that's the purpose for which this was primarily developed, to assess patients who are in hypovolemic shock. So it's actually, when you apply it, it's quite useful in determining the adequacy and also predicting the severity, the trajectory of disease, and how much, say, of blood products you have to give a patient who is in traumatic shock. So that's a useful thing. By definition, I don't know if to call it shock index, because index means it should be unitless. But trust me, use it. It helps a lot to predict that you're somewhere. So if the heart rate is still quite crazy high, it means you haven't adequately resuscitated this patient. You probably need to give a bit more fluid, maybe give a bit more blood product. As the ratio drops, it tells you the patient is getting closer to adequate intravascular resuscitation. We're together. So that is a very important test. They're trying to modify it from using systolic blood pressure to using things like the mean arterial pressure, and also the modification through things. I don't want to tell you everything about it. Kindly read it up and apply it in your practice. You'll see a trend towards the adequate resuscitation. Now, this is interesting. Capillary fill time has recently been validated by this study, the Andromeda shock study. It's a simple test that's available to all of us. Even you have a capillary fill time right now. Try it, okay? Essentially, what they do here is you get a glass, you compress the capillary bed of the finger, of the earlobe, of the nostril, of the skin somewhere, and so on, and give it time to see how soon it refills with the blood. The sooner it refills, the better. It suggests that microcirculatory perfusion is good, okay? And here they were comparing it in this trial to using lactate clearance, and actually it achieves perfusion endpoints much quicker than following lactate. And yet you need to spend money for lactate. Here you just need some muscle, compress the fingertip. Now, because some of you are strong, really, really strong, they decide to validate it using sorry. They say to use a glass slide, because some of you will compress the vessel such that even the most perfused patient ends up appearing to have a very slow capillary fill. So using a glass slide, you compress a nail bed until it blanches, then release it. So the compression is about 10 seconds, right? So this makes it more reproducible. Then this is available to you in all monitors these days, the peripheral perfusion index. Peripheral perfusion index is that small number you'll see written underneath the SpO2 or adjacent to it. Okay, many of times my nursing staff ask me, what is this number saying? Sometimes I also find my residents asking. Occasionally, I have a colleague, it's okay, it's new. It's somebody's PhD work, and now it's embedded in all monitoring devices. So all these machines you see that are displayed here by Mindray and other monitoring manufacturers, they embed perfusion index. And essentially what it's looking at is it's comparing the pulsatile to non-pulsatile blood flow in the nail bed to give you a clue about the terminal blood flow through tissues. It's again something quite useful, and there's an algorithm for use for this. A perfusion index above 0.6 suggests that it's adequate blood flow. If it's less than that, then you go through different algorithms to determine why. Remember, of course, the patient is hypothermic, is on vasopress, and so on. It can be altered. I just want to switch here to the biochemical ones. You've all heard about the lactate, mixed venous oxygen saturation, PCO2 gap, and base excess. Lactate is the sweetest one of them. I just want to talk about it because we misuse it. Lactate is produced by metabolism in our cells as a way to bypass failed Krebs cycle function for a moment until you restore the function, and then it is reversed to bring back those carbons into the Krebs cycle to make ATP. So in some situations, the production of pyruvate, the precursor to lactate, can increase so much that the Krebs cycle is not ready for all of it, so it's partially shunted towards lactate. And so when you slow down and stabilize, then it reverses. So we see it a lot in situations where you have physiological stress, catecholamines, adrenaline, use, salbutamol, etc., it goes up. Sepsis, for example, essentially activates physiological stress. Cardiogenic shock activates this. So when you're looking at lactate, you have to think about all the physiology that's going on and driving it. Nonetheless, a raised lactate is telling you that there's some level of stress in the patient. If it is type A lactate, type A lactate is due to perfusion. There's type B lactate, which is due to poisoning of this apparatus of energy production. Okay, maybe the mitochondria are not able to do this because there's some enzymopathy. Maybe there's some medication you've taken, for example, metformin, among other things. So you have to put this into consideration. The key thing about lactate is that a high number tells you there's a problem, right? But the most important thing is how fast are you clearing it from the body. That's going to be more useful. So remember to follow lactate clearance rather than just a lactate number itself. And a raised lactate doesn't tell you need fluids. And a raised lactate doesn't mean that the patient will not benefit from ringer's lactate. Mixed venous oxygen saturation. Blood flows through the body and is extracted by different tissues. Then it comes back to the heart as combined blood. Okay? And it flows to the terminal part of the heart called the pulmonary outlet, where now the combined blood that went to the heart muscle, to the brain, the skin, etc., has now combined to eventually flow into the lung. So mixed venous oxygen saturation is the saturation of blood taken from the pulmonary outlet in there, or even the pulmonary artery. After you've pushed the catheter all the way there, that catheter is called the Swan-Ganz catheter. As you can see from this diagram, there's a small catheter here. You may not be able to see it very clearly, but it goes all the way into the heart and is impinging in the pulmonary artery. So that blood is called a mixed venous blood. It's the one that's now going to the lungs to be oxygenated into arterial, into capillary, into pulmonary venous blood that goes back to the heart. There's some blood that did not go to the lungs. It bypassed the lungs, came back straight to the heart and oxygenated. Then that dilutes the oxygen saturation, such that the ultimate saturation of blood in the arterial side is less than 100, okay? And then that goes to tissues. So, again, at the beginning I said blood goes to tissues, is extracted at a constant rate, and then returns to the heart. So if you have a significant drop in the amount of oxygen saturation in the mixed venous blood, then for sure there's a problem with perfusion. That's what it's telling you, okay? So we no longer put these special catheters that go to the pulmonary artery. They're called Swan Ganz catheters. They come with a lot of complications. But my guys from cardiac anesthesia do that, right? I mean, they are special, right? Clap for them. But even for them, it's occasional. It's rare that they use them, right? Now, we use a surrogate, which is called a central venous oxygen saturation. So instead of going all the way to the pulmonary artery, we just put a central line. As long as it's well placed at the arterial cavo junction, it's going to reflect the central venous oxygen saturation. It's going to be less because predominantly central venous oxygen from a supra-diaphragmatic line is recording from tissues that extract more, which is called the brain. So the saturation there, the limit's about 65%. So if you have a central venous oxygen saturation less than 65, it suggests that there's a problem with perfusion, okay? That is on condition that the oxygen that you deliver to tissues was adequate. Meaning that the hemoglobin was good, the oxygen content of arterial blood was good, okay? Similarly, there is blood in the arteries that goes all the way back to being blood in the venous system. So when you take blood from the artery, you take a blood gas from that, you get a CO2, they call it PCO2. Then, if you took blood from the central vein, you would get the partial pressure of venous carbon dioxide. Okay? So now, if the difference between them should be very tiny, reason being that carbon dioxide diffuses 20 times faster than oxygen. Therefore, as long as your ventilation is good, you should be able to clear carbon dioxide such that the gap between the arterial and venous should be so tiny. Okay? Once you notice that the gap between CO2 in the artery and CO2 in the vein is increasing, then you are dealing with a problem with the flow, okay, with the cardiac output. Okay? So this is rarely done, but ideally in your unit, you should be, when you take a blood gas in a patient who's in shock and you want to use this, you should be able to check the central venous gas as well. Then you compare the CO2 in the two. Okay? But of course, always look out for the ventilation bit. Maybe you have a plugged filter. Maybe you're giving very tiny blood volumes and trying to kill the patient that way. So you could fix that first. But either way, it's a diffusion. It's not a diffusion limited issue. So in this situation, the patient should be able to maintain the gap being less than 6, even in respiratory failure. Okay? Cool. So, sorry, now I'm going to the more advanced things that we probably don't see often. But again, our cardiac guys, Dr. Bruno, I don't know if you guys use this yet, but you probably should be using it sincerely. This is a near-infrared spectroscopy tool that we use for non-invasively assessing the oxygenation of organs. In this particular case, in cardiac, when they put patients on bypass, they are concerned about the blood flow to the brain. So in that case, they apply these electrodes to the face, which record the blood flow to the hemispheres. Gives a good clue, rather than the past where we used to inject, to insert invasive devices to the brain itself to measure tissue oxygenation, or place one called the jugular bulb oxygen, a catheter into that and potentially risk bleeding and dissection, other complications. Now you just apply a device on the face. I've used it before. We are not exactly the same, but it's life. Okay, but so it's quite a revolutionizing neuro critical care, trauma, and cardiac surgery, and I hope that in your practice one day you'll be able to look at that. Now this is just now futuristic medicine. Okay, it's actually applied in ICUs very far from you. This is when we are trying to image the blood flow through the microcirculation. There are some special devices that are called the handheld vital microscopes. They apply different styles to looking at the blood flow through the tiny circulation. In this particular case, this one here is called the orthogonal microscope, where they pass light of a special wavelength, which is called isosbestic wavelength, which is the light, the wavelength at which the different absorptive properties of the hemoglobin meet for oxygenated and deoxygenated blood. So that means the hemoglobin in the capillaries will absorb all the light and they appear black. So now you look at black things running through these tubes and feel good, knowing that actually they're inside the blood vessel. And now looking at the carousel flow, you know whether it's adequate perfusion of the microcirculation or not. So they place them in the mouth, usually just on the side of the tongue, but you can also apply it in different areas like the nail bed and so on and so forth. So there are different adaptations of such imaging techniques. This is next generation stuff. We're not going to talk about it because we're not going to see so often in our practice. And there are different modalities that are applying the similar physics or technology to giving information. Of course, some of them may never make it to clinical practice. I'm not going through all this stuff here. It's like, I just want to show you that I've read a lot about this stuff. But essentially what I'm trying to tell you is that all these things I've talked about cannot be applied alone. You need to apply multiple clinical signs to derive the appropriate information about the patient. That means examine the patient. Never use technology to replace your clinical signs, okay? A good clinician sits bedside and examines the patient over and over and does not go to apply a clinical tool to give him the answer or her the answer. I'm going to be quite gender neutral here. A good clinician develops a hypothesis, then only goes in to confirm it or refute it. You don't throw a stone to the bush and expect a hyena to jump out in Kampala. They're not here anymore. So kindly go out there and kill as few patients as possible, remembering that you will achieve this by always having a hypothesis